Welcome. Today we're diving into cheek reconstruction, really focusing on what you need for board exam preparation.
Exactly. It's about a systematic approach, defect analysis, and knowing your options.
We'll be emphasizing anatomy, those aesthetic units, and how they guide the reconstruction.
Absolutely. And you really can't overstate the importance of knowing the anatomy cold. Let's start there.
Okay, anatomy. Soft tissue layers first.
Right. Particularly the SMAS, the subcutaneous musculo-aponeurotic system. It's that key fibrous layer under the skin.
And crucially, the motor nerves generally run deep to it, while sensory nerves tend to be more superficial. That's a key relationship.
Definitely. And then you have the muscles.
Like the lower orbicularis oculi, zygomaticus major, and minor for the smile.
Levator, labiae superioris, aleci nasi, the superioris itself. Masseter, buccinator, all crucial players.
Understanding their function helps predict deficits and plan the reconstruction.
Precisely. Then there's the vascular supply, primarily terminal branches of the external carotid.
Yes, the facial and superficial temporal arteries mainly. And the veins generally follow suit.
Okay. Sensation, that's trigeminal nerve territory, isn't it?
Correct. Maxillary and mandibular divisions, giving you the infraorbital, zygomaticofacial, buccal, mental, auriculotemporal.
And the great auricular nerves, don't forget that one.
Good point. And motor supply.
Branches from the facial nerve mainly, but also some trigeminal contribution.
Hmm.
And lymphatics draining mostly to parotid and submandibular nodes, worth remembering.
Okay, so that's the groundwork. Now, aesthetically, we divide the cheek. How?
We think in terms of three overlapping zones. Zone 1 is suborbital, Zone 2 preauricular, and Zone 3 buccomandibular. It simplifies planning.
Right. Let's define those. Zone 1, the suborbital area.
It's bordered medially by the nose-cheek junction and nasolabial fold, laterally by the sideburns edge, inferiorly by the gingival sulcus, and superiorly by the lower lid.
And it has subunits too, A, B, and C. Cervicofacial flaps are often a good choice here.
Correct. Now, Zone 2, the preauricular zone, that runs from the top of the ear-cheek junction.
Across the sideburn medially to the malar eminence and down to the angle of the mandible.
And again, cervicofacial flaps are frequently used here as well.
Then Zone 3, buccomandibular, lower cheek, potentially involving oral lining and full-thickness defects.
Yes, it sits below Zone 1 and in front of Zone 2. And importantly, cervicofacial flaps are generally not the primary choice for this zone.
Okay, zones defined. Before picking a flap, defect analysis is key. Simple versus complex.
Exactly. Simple is just skin and subcutaneous tissue. Complex means deeper stuff. Muscle, nerve, parotid, mucosa, even bone.
And the guiding principle is always anatomic reconstruction, layer by layer.
Whenever feasible, yes. Including facial nerve repair if needed. Complex cases might mean contour revisions later on, too.
Right. Let's get into the zone-specific options then. Starting with Zone 1, suborbital, small defects.
Primary closure is an option if you orient along RSTLs, those relaxed skin tension lines, but you have to be really careful about lower lid distortion. Ectropion is the big risk.
Skin grafts.
They're an option. Full-thickness grafts, say from preauricular or postauricular skin, give better aesthetic results than split-thickness usually. Better match.
But there are limits, right?
Yes, if the defect's deeper than about 5 millimeters, grafts tend to look quite patch-like. Suboptimal, and templates are vital for sizing.
What about local flaps for smaller Zone 1 defects, say under 4 centimeters?
You've got the usual suspects: rotation, advancement, transposition. VY flaps, especially inferiorly based, can work well.
Rhomboid flaps.
Very versatile. Aim to place the donor scar along an RSTL. The standard 60-degree angle usually works best.
Bilobed flaps. I know the Zitelli modification is popular.
It is good for central defects, distributes tension.
Yeah.
But the downside is multiple scars. Forehead flaps are another possibility.
And with forehead flaps, you need that pinch test to make sure the donor site closes primarily.
Absolutely. Now, for larger Zone 1 defects, over 4 centimeters.
That's often cervicofacial flap territory, isn't it?
It is great for large surface defects, good tissue match. You dissect posteriorly along the hairline, undermine to reduce tension.
Dog-ear excision is usually needed. And preventing ectropion is key anchoring to periosteum.
Yes, anchoring sutures to the zygomatic arch and inferolateral orbital rim periosteum are crucial. Maybe even a lateral canthopexy.
What about the flap's vascularity, especially distally or in smokers?
That's a real concern. often why a deep plane cervicofacial advancement, including the platysma for better blood supply, is preferred for malar, lateral orbit, or temporal
Or
reconstructions.
tissue expansion.
It offers potentially the best color and texture match, fewer scars, but it takes time, multiple stages. You often need custom expanders.
And you need to plan the incision, the size, intraoperative fill, delayed expansion.
Overexpansion usually to compensate for contraction, and capsulotomy at the time of flap transfer, though typically not capsulectomy.
And if you need to resurface a whole subunit or have a massive defect.
Then you're looking at free flaps. Radial forearm, ALT, scapular periscapular are common workhorses.
Any salvage options for zone 1?
Temporalis muscle flap is one, but it causes temporal hollowing. Cranial bone grafts are another, but healing can be poor with thin coverage.
Okay, let's shift gears to zone 2, the pericular area. Reconstruction here.
Often simply, there's usually more skin laxity, so primary closure is frequently possible.
And full-thickness skin grafts tend to heal well and can be hidden nicely.
Right, local flaps can borrow that facelift-type laxity. Neck extensions can bring in good vascularized tissue, too.
What about regional flaps for zone 2?
The anteriorly based cervicofacial flap works well for posterior or large anterior defects. It relies on facial and submental artery supply.
And the cervicopectoral flap.
Good for larger defects, maybe 6 to 10 centimeters. Uses anterior chest skin based on internal mammary artery perforators. You typically elevate superficial to the pectoral fascia.
Submental flap.
Another option, based on facial artery perforators. But you have to consider the hair-bearing skin in men.
Tissue expansion and free flaps are similar options as in zone 1.
Pretty much the same indications and choices apply.
And salvage for zone 2.
Similar list again. Temporalis muscle, delta pectoral often delayed, pectoralis major, trapezius, latissimus dorsi.
Okay, zone 3. Buccomandibular. This often involves more than just skin, right?
Definitely. Full thickness defects mean you need lining, potentially lip reconstruction too. Watertight closure of the lining is non-negotiable.
What are the options for that inner lining?
Quite a few. Hemitum flap, turnover, or hinge flaps from adjacent mucosa, though they need donor site coverage. Buccal fat pad flap is elegant for smaller defects.
Suture crossover, FAM flap, facial artery, mymucosal flap. Submental flap can sometimes provide lining.
Or you can place a skin graft in the deep surface of your main reconstructive flap prelamination. Or even use a free flap with 2 skin paddles, like an ALT.
What about simple closure or grafts in zone 3?
Primary closure is tough. Not much laxity, high risk of distortion. Full-thickness grafts tend to look very patch-like here.
So local flaps are more common.
Yes, rotation, advancement, transposition, rhomboid, VY, bilobed again. And if a scar crosses the mandibular border, a W-plasty or Z-plasty can help camouflage it.
Regional flaps for zone 3.
Inferiorly based advancement flaps, submental flap again. Deep plane composite flaps are possible but carry a higher risk of nerve injury. You need to be careful.
Tissue expansion and free flaps.
Similar principles as zone 1. For defects over 10 centimeters or full thickness, free flaps are often needed. Fasciocutaneous ones like FRFF, ALT, scapular, lateral arm usually give the best tissue match.
Salvage in zone 3.
Deltopectoral, pectoralis major, trapezius, latissimus. And for lower defects, maybe an internal mammary artery perforator flap, an IM flap.
Let's touch on contour defects. These aren't just from cancer ablation, right?
No, you see them with Romberg's disease, scleroderma, lipodystrophy, branchial arch syndromes, trauma, radiation atrophy.
Reconstruction options there.
Depends on severity. Injectable fillers for minor issues, but volume is limited. Dermal or dermal fat grafts, though fat reabsorbs unpredictably. Autologous fat grafting is very common now.
Local tissue.
You can use local flaps, sometimes deepithelialized platysma flaps, or the buccal fat pad. For bigger deficits, deepithelialized free flaps, FRFF, ALT, scapular work well.
And revision procedures. They seem almost standard after free flap reconstructions.
They really are. Standard of care, you could say. Usually done at least 6 months post-op.
What's involved in a typical revision?
It's systematic. Flap debulking, maybe liposuction, sharp excision, curetting. Treating the flap's SMAS, layer application, or suspension. Scar release is important.
And aiming for slight overcorrection at key points.
Yes, like the oral commissure canthal regions. Providing lower lid support if needed, maybe resuspending the flap, and often final touch-ups with autologous fat grafting.
What about complex reconstructions involving bone?
Now you're talking large tumor ablations or major trauma. Restoring bony contour is fundamental for symmetry.
So osteocutaneous free flaps.
Exactly. Scapular periscapular with bone, osteocutaneous fibula, the workhorse for mandible, DCIA, deep circumflex iliac artery, or even FRFF with radius.
And large defects involving maxilla, orbit, palate often need multiple stages.
Almost always. Planned multi-stage reconstruction using a mix of local flaps, muscle flaps, free tissue, nerve grafts, bone grafts, or osseous-free flaps. It gets very complex.
Okay, let's try to summarize some key take-home principles for the exam.
Definitely. First, aim to rebuild or resurface entire aesthetic units if possible. Looks much better.
Use the contralateral, the other side, as your template. Symmetry is key.
Make exact templates for flap design. Don't guess.
Try to avoid vertical incisions anterior to a line dropped from the lateral canthus.
Hide scars where you can blepharoplasty incisions, facelift lines, nasolabial folds, or along RSTLs.
And crucially for Zone 1, prevent extropion. Anchor that flap to periosteum. Consider a lateral canthopexy.
Those are absolutely critical points.
So to wrap up, successful cheek reconstruction really hinges on understanding the anatomy inside out, carefully analyzing the defect, and then choosing the right tool for the job from that reconstructive ladder, always considering those aesthetic units.
Well said. And there are excellent texts dedicated just to local flaps in the head and neck, which are worth delving into for more detail.
A final thought, perhaps. Always consider that interplay between form and function. Getting the appearance right is crucial, but so is restoring movement, sensation, and avoiding complications like ectropion.
That's the ultimate goal in facial reconstruction, isn't it? Balancing both.